You already had a long day.
Yes. They wanted to wait.
And now me just telling about a personal story. That is how I got personally into environmental medicine. I'm a neurologist and psychiatrist and doing some psychosomatics for many, many years. And later on, after 20 years of working in the field, I got engaged in environmental medicine. How did I get into? Oh gosh, this is just the introduction. I just go through by it fast. That's me. So, 20 years ago, more actually, no, 25 years ago now, to my psychosomatic ward, there were coming people with all kinds of multi-system disorders. And they went through the whole system. They had ENT problems, they had gastrointestinal problems, they had pain problems, they had sort of rheumatic type problems, you know, fibromyalgia type, you all know that. And it was looked after from all kinds of specialists, all kinds. They went through the whole system. And the specialist didn't, the GP, anyhow, he didn't know what to do with those patients. And the specialist didn't get the right diagnosis because it no real biomarkers whatsoever. Maybe some sort of inflammatory thing, maybe some little bit, maybe even in the EEG something, or but not much. But not much. So those patients usually end up where? Where do they end up? Psychologist, psychiatrist, and at that time, and be careful because of myself, I said psychosomatic and psychiatry is the prostitute of the normal medicine. You know, when that part of the medicine didn't find anything, then it had to be a psychosomatic condition. But of course, I followed. I said, okay, I try my psychological, I try to treat them, excuse me, now I'm thinking German, it's not good. You know, I have to translate internally, so it's not so good. So I had this psychological approach and psychotherapeutical approach, even giving some psychopharmaceuticals, like on the tranquilizer side, on the antidepressant side, whatsoever. And sometimes it helped somehow, because all those people, all those patients, they were quite often under high stress, they were anxiety, there are a lot of worries, and they even had some panic attacks. And so that's, I don't know, it's confirmed, but it really didn't help. So that help came, as I already told, this friend of mine. He's a neurologist. I just talked to him a few hours ago. Right now he's very ill. He's at my age, so one can get ill in that age, you know. He said, I observed illness and what I described, you know, this all multi-symptom part and focusing maybe on depression. I observed those families, they all had that type of multi-symptomatic disorders, conditions. And because he actually was more neurologist than psychiatrist, this is in Germany or on the continent, we quite often have those two very close together, not in the Anglo-Saxon part. There is neurology more to the internal medicine and psychiatry more to the psychology. But at home, we quite often have those combination. Then we call it Nervenarzt. It's not too bad to call it like that. And in that situation, he was more of a neurologist, and he measured, he said, why are there some small fiber neuropathy? And they don't have diabetes, they don't have other major signs and symptoms from neurological disorders. Why is there small fiber neuropathy? Why are there some other, he did some brain mapping things at that time. There are some things, and then he went into history, and this is actually the main point in all environmental aspects in environmental medicine. History, history, and history again. And right now, today I had a young lady, she didn't want to tell me about part of her history. I could understand it then, but you have to go 360 degrees. So you ask for everything. You ask for psychosocial, you ask where they live and what kind of environment is there. You look for their diet, you look for whatsoever has to come together when you're living and in some certain place, or what relationships you are to others, and whatsoever, what kind of special, or smoking, drinking, or you know all this, you do that. But he looked at their living place, because this is strange. Children are getting ill, the mothers are getting ill, the father most of the time much later. But at that time he was most of the time out of the house. And then he found that they were really successful families. They lived they looked in new buildings. They lived in new buildings or in renovated buildings. And at that time in Germany, people, that was in the 70s and 80s, and for the time being, people had quite a bit of money again. So they rebuilt good houses. And I wonder whether it's your place, but in Germany, you know, the Germans are a special kind. In some ways good, in some ways not so good, I know. But one of the things is, when you promise a German that his house, at least the inside, the wood, will last for 6,000 years, you're putting a lot of wood preservatives on it, you have convinced him. So a lot of people were putting wood preservatives in their houses. And then, now here comes the problem. And I think this is a problem that will repeat on different levels in every place. He promoted, and others in Germany too, because this was soon pretty evident, measuring the level of those biocides in the blood of the ones who are living there. And they all said, this is just above the average everybody's got, or not even below. The toxicologist then said, well, this has nothing to do with their condition. Nothing. We have those measurements done by all the ones who produce that stuff. But you know, living in a place, kids live about 60 or 70% of the time in this place where they sleep and work. Women who stay at home, they stay about maybe 80% of their, all the time there, especially during night, sleeping there, where you have to regenerate. And the husband who's out, he's maybe just 50% of the time. But all these multi-system problems started, some after months when they got into the new house, some after 2 or 3 years. So then you saw another thing in environmental medicine, the exposure or the load. It doesn't tell you right away when signs and symptoms start. For some of them, it took just months, and then they were pretty anxious, said, well, it has to do something with our home. But with others who already stayed 5, 6, 7 years. So we found, later on, we looked on a study on that. You know, it really for months to years. And again, then we got engineers who measured the level of those biocides in the home. And yes, we found them. We found the lindane, the pentachlorophenol, and what you know about those things, this was the rubbish of the chemical industry. And there were, of course, some dioxins and stuff like that. Then is the mixture. And usually the science look just for single substances, not for mixtures. And I tell you, this will be repeated decade after decade with different substances. So the next one, this was this part of substances, but later on we have the parathyroids. But that came later. But this time it were these. And later on we even had a big process in some high court in Frankfurt. I did some expertise on one of the families, and we won. And they stopped it, but they looked right away to other substances. So, to keep it going, we said, people, get out of that environment. And the persons who already had those signs and symptoms, they said, yeah, we noticed when we were in vacation, things were fine. But before that was defined as psychosocial relief. Vacations is nice, then you don't have the daily stress and everything, and then everything is fine again. But quite a few people, they didn't have any relief when they got out, so they were a little bit longer in that exposure. So they said, either you have to renovate your house altogether, or you get out of it. And many of them got out, and said 50% of the patients became fine again. So we had a close relation to exposure and their symptoms. Even then, that was rejected. Said this is something we have talked to them and say this is no. What is hoax? It's not. It's something that's in their mind. Then, but 50% of those patients, that was still in the end of the 80s, they had problems, the same signs and symptoms, but they told us, now, I'm not just reacting at my home. I start to reacting in public places. I start reacting in some restaurants, and I will start reacting in people's home where no wood preservatives are. So now we are coming to one of the things I hope you're not that much confronted at your home, but here it's quite a percentage of people. That means, say the statistics, about 15% of our population has defined allergies, but another 15%, and quite a few of those with real allergies, have those sensitivities and intolerance too. So there's a high percentage of the population who has to cope with these sensitivities. And when it comes to a severity of that condition, then of course it's a smaller, much smaller percentage, much smaller. But look in the States, look here, Europe. I don't know how it is in Asia. I don't know, but here you have about 1% of a population where it's a real medical condition, where it's really compromising daily life, where it's really sort of reducing functionality in a way that quite a few people cannot work anymore, and they don't get any, benefits whatsoever, but because when they say it's just from sensitivities, they say, well, you have to go to a psychiatrist or psychologist first, or you do some behavioral cognitive training, or you have to do some, what else? Some graded exercise when there's a lot of fatigue with it, and all this, you do this, or you take some antidepressants, then things will be fine. And when that doesn't happen, those people are really in a bad situation. This friend of mine, he said, look, I found from Ashford and Miller America was a little bit advanced in all these things. Those things we were run into, they started in America about 30 years before. Randolph found those hypersensitive, multiple chemical sensitive patients in the States already in the 50s, and he wrote about it. And in this comprehensive review, I found a guy who wrote what I saw, and this is always important. Rely what you see. Don't rely on the textbook. When you get into new things and you want to find it in the textbook, you won't find it. You know, it's the same thing when a person experiences something new in dysfunction and goes to a GP, and the GP hasn't seen it. Where does he rely on? He calls you, he calls the professor. And the professor hasn't seen that either. And they give them their opinion, but they have to, because on their own. They give their opinion and then goes back. Be so open when you see something new that you say, well, on my experience, this is real. It's not something somebody thinks of. Already talked about this. And now it comes to structure and how things get into structure. Maybe that's similar at your place. I had a good friend, a toxicologist, an assistant professor. I worked together at that time. Most of the time I had a lot of drug addicts. And drug addiction is toxicology too. And this toxicologist worked on what kind of toxicology is with all the different drugs. And he asked me, is this neurologist who is in private practice, is he reliable? Because he brought his observations to the toxicology to our nearest university in Kiel. And they said, well, that's not true. That can't be, as I told you. And I said, what he observes is real observation. And then this guy believed me, and then my friend got his observations into that toxicology, and Professor Wassermann then accepted. Before that, he sort of rejected. So he was then one of the first real professors who seemed to accept this. And then the allergologists, who know, you all know, hypersensitivity, when we didn't know the mechanisms, was all the hypersensitive, allergy was all the hypersensitive reactions. So that, but then in the 60s, we defined what allergy is on those in the immune system. And what didn't fit into these definitions was put aside. And again, it were the psychosomatics, people who should take over. We do have somatization disorders. We do have somatoform disorders where things come from psycho to soma. We know a lot of examples, all of you know. But we often have the situation that from pounding heart, palpitation of heart, panic is triggered. You can have it the other way around, but you can actually start from every place in your system to spread, either to the more somatic side or to the more vegetative, psychological side. And the allergologists, they said, well, this is, no, it's not our way. So me, as a psychiatrist, had to take over on this practical side. And I'm still not a specialist on all these other immunological side, but I did some clinical work. We just talked psychiatry versus toxicology. So, we already talked about that too, the history that was in the 80s to the 90s. You see, difficulty concentrating, headaches, depressive feeling, frequent, but that everybody should make somehow suspicious. quite often infectious thing, repeating normal colds in 4 weeks intervals. This is not typical for any, we later make some studies on for the ordinary psychosomatic people. What means ordinary? Rheumatic-like pain, gastrointestinal symptoms. All the different specialists, no. And then psychosomatic. And I took over and couldn't help either. But then, I told this story already. But now there's another point. We shouldn't overdo it. It's more than important. A lot of my colleagues who got into this work, they said, we can prove what they had on different neuropsychological symptoms. This is a organic brain syndrome. This is a neurotoxic syndrome. Be careful to use then words that are already sort of put together with certain other definitions and other histories. Just describe, and don't say, oh, he is an organic what I said, organic brain syndrome. He has neuropsychological signs and symptoms. And you just told us, Basan, that, so yeah, of course there might be some infectious, some genetic or what's background behind in doing that. But before we really know the mechanism, we should stick to description and not just banging some diagnosis in it which is already filled in with other sort of disorder or medical conditions. Mild toxic encephalopathy. So that was then 10 years later. So in the meantime, we taught quite a few doctors, GPs and ENT specialists and other doctors. We taught them in a 120-hour to 180-hour course and let them also work. It's places where environmental medicine was step by step introduced. And they did a more thorough look to possible environmental backgrounds. And most of the time, and you heard it, I think, more often than once, defining the exposure, reducing the exposure, or reducing, you quite often heard the word load. I'm very careful with load too, because you might have a toxic load of, maybe at your area it's more relevant. I just had, again, one of those patients who had eaten a lot of raw fish. And you know how much your countryside actually was a dump site of European chemical industry as far as I could see in certain areas. Is it true or is it not?
Yeah.
Wow, horrible. Because it's too expensive, too high to cut things. So they came and built their things up there, and they got a lot of chemicals put into the cycle of life and eating again and whatsoever. And so most of them, or 55 to 30% got better, but that's again a problem with load. Quite a few people say, and you heard it quite often here too, maybe for Cipro, wake up Cipro. No, you don't sleep. No, I'm not saying that. The point is, when somebody reacts, does he have a lot of molecules to detoxify or not? I know it now. I just had this fellow from Italy. He had a really very, very high mercury level. Then we really talk about detoxification. But when somebody gets a sniff of something and he reacts. And literally he has load, but it's not in a matter of getting away masses of that substances. You have to find out. And this is a tricky thing, very tricky thing. Coming from sensitivity and reacting to all kinds of things that looks like as if you've been having a big load of those toxic substances in you. And there's even some ideology going within environmental medicine, and you have to be critical on that. And then you have to rely again on your observation and that personal history of that patient. We should actually train that here somehow, at least for a few examples, with patients, new patients, where I got really, oh my, you always get confronted with the whole of the medicine. And I didn't remember some of the autoimmune disease things today. In this one, of course, I got the information from the patient because this is another point. When patients in that field for a longer time in there, they get informed and they don't see you at the first time, at the one on top who can tell everything. They quite often know more than you because they can specialize on their condition and they get special informed, while you sometimes have to, oh, I have my Harrison there close to me, or I have my special neurology book there. And then, yeah, see, that's my loss of what Jean was talking in the morning about. So then they went to our environmental unit. And we come now to the next problem. When you want to treat or follow for a longer time those very sensitive persons, it's not like allergy, because allergy usually with allergies you can define certain fields and people can avoid, and then it's fine and then they function fine. But those environmental sensitive, I say it in a broad sense, but you can define the substances. Those are the substances you can have at every place. And so you have to have a place for them to settle down, not to get provoked. And the first thing is that you yourself have to change your behavior. When I started this, I was a lover of expensive aftershave. When I got to do this environmental unit in Dallas to Bill Ray, I saw how they almost fainted when I got into there, and they got a pale face. And then I asked them, and they told me, by some reason I already stopped using any washing stuff or makeups with any kind of scent. I already did that. I didn't know why, but I still used that other stuff. And then I did this, I showered. And I had really difficulties to tell us when we started, my staff at the environmental unit. I said, what, just a little bit, But after a while, it's thinking, for the ones who react and the ones who don't use. But just one thing. We all have, when we are not under stress, and we come close together, we all have actually wonderful scent. We don't have to put anything on top of it. Maybe when we go to some event 2 or 3 times a year, but all the other time we don't need to use all those scents and perfumes. It's again a matter of industry, and they put so many new things into it. We really don't know what it does in the long run. We are sort of doing permanently trials for the chemical or for the other industry. Permanent. This is, Basta, it's not conspiracy, it's reality. Accept it. And no, because they put something new in, and you know it. Our evolution didn't change within decades. Our evolution changed within hundreds of thousands or thousands of years. We were just talking about the cow. This is a matter of thousands of years. And what we're doing is a speed up and that we should adapt to new environments. That we actually just find out afterwards what we shouldn't have done. Remember, how long it takes that you get something wrong from cigarette smoking. How long does it take? How much? How much? The word. 20, 30 years, 40 years even. Then you get the result. I had a story in our parliament in the 50s. There was a woman who said, I cannot tolerate this, what you men are smoking here. And they all laughed at her, in the parliament, to say. Now think, we banned from public places and all in the smoking. And even the smokers now, I guess some of them, maybe not. They don't say it anymore. They go outside and they hide themselves, And China, you see what it does. They get more money there, and they go through. I hope it is not in Thailand. And yeah, okay. And then they found out after 20, 30 years in the 60s, they said, well, it promotes this. And it took another 40 years to get this knowledge transferred into reality and the consequences out of it. But this process we're doing all the time, with different stuff now. Perception of the problem in health personal society, I just said, at my place, I was at that time Napoleon. I was the medical director. I could more than here. I could say, "You don't do that." No, what you do? You're interfering our personal freedom. I said, "No. If you use it, you hurt others, and this cannot be done within the hospital." And they stopped. There were the 6 nurses, and now comes the next thing that you should have in your mind. They stopped it, and 2 of the nurses said, "Oh, I didn't know that I couldn't have tolerated it all the years before. Now I know when I get confronted with it, I react to it." This is done adapting. It's called maladapting, and we can maladapt to a lot of substances for a long time. I think Jean was talking about this, but this you can have it in a clinical way. What we did here on scientific, it's always a little bit difficult to translate into normal clinical work. It has to be done, but it's quite often pretty difficult. And so they were convinced. They said, okay, that can do something wrong. And I experienced myself. And the more you have self-experience, of course, with those things, the better you can feel and listen what they tell you. Yeah, here's the point. This is the prevalence I was talking about. And now, again, I just started before. I just repeated a little bit. I hope we have the... you can start at any place of your system. Any. You can start with a psychological problem and you get physical problems, and you can start on the physical side and you get psychological problems. One connection to depression. It's an easy one. You all have it in your textbooks. A low thyroid, a very low thyroid, what does it do? It makes you depressed. And when you give then an antidepressant, you kill the one. So you know that you always have to look for proper function of all organic systems. You have to look for proper function on the endocrinology or whatsoever. And you do it, I guess so. And Yeah, see, there was not one multiple chemical sensitive patient who wasn't sent to a psychologist. One I still remind, and that it stays, then you had, he finally was trained behavioral therapy, not having anxiety for all the chemicals, and then he was especially sensitive to car exhaust. So when he had now a good psychological training, and then he was supposed to stand on the roadside and take a deep breath and say, "Nothing happens to me." That's what the psychologist said. And he collapsed. So then he said, well, no, it couldn't be. But this is not, there's now something, things are coming together now, the last 10, 15 years. Then I talked about the biopsychosocial model, things coming from all different sides. But this is often used, and in my place later on, used as an excuse for not starting with the physical part. That is, in medicine, you always say, as I learned it decades ago, physical goes before psychological. It's nothing against psychological, but if you miss an underlying physical problem, you did something wrong. And when you just put it on the social side, psychosocial, that means you look too much in the internet, and so too much conspiracy things, and then, no. Of course, there's behavioral part of it. When you have somebody who has a disability or reacting to whatsoever, you have to train him how to cope with. Not just treating it and reversing it when possible, but how to find a way to get better along with it. And this means for the ones who are with the sensitivities, what does it mean? For example, they learn not staying longer in the supermarket than 10 minutes, because after 15 minutes they know they react too much, that they have to put themselves down for the next couple of hours because they are fatigued, exhausted, have migraine and whatsoever. So they know after a while, and you support this, how they find ways to serve through our society with that disability or this condition. This is one thing. Then you need the avoidance and lowering all kinds of exposition. And now there's another thing, and I hope you can put this in your memory, and when there's something new coming up, take it serious. And the earlier this is with all other disorders, the earlier you get to the point, the better chances the patient does have. Underlying factors, now something what we learned here. I haven't learned it at my place. In the 1990s and the first decade, not long I was in my place I run, was we have a lot of sensitive patients with all kinds of, as I told you, all kinds of signs and symptoms. First we looked just for the viruses. That worked quite well for a certain group of patients. But later on, and there was the information coming from islets and from other people in the United States, because they were, again, a little bit in advance to what we're doing in Europe. And we found that a lot of those patients, besides their intolerances, sensitivities, allergies, they had underlying chronic bacterial infection. I wonder what kind of epidemiology you get at home, and what you especially look for. But I think it's an extreme important thing. And we have now sometimes, maybe this is bias, because people hear what we're doing, they said, I have the suspicion there could be borreliosis, something like that. So they come in more to us. But I was really astonished when we addressed it, not just the sensitivities and the intolerances, we addressed this chronic infection, although this is another huge discussion, you had it before. But this is again, this 360 degrees looking around for one patient when it is a complex thing. To look for that. And then you really have to know where you rely on. Quite often you come in conflict. You rely on your clinical observation, or do you rely on the lab things you get from there? We had this. Oh no, Sipro is gone now. We had this now last a couple of times. For example, we have one with not many signs and symptoms, just a little bit maybe, or even none, and then we get something that is a severe on the lab side. You know, it says, well, this one man has a borreliosis. What to do? It's not easy. On the other hand, we have just small indications from the laboratory side, but we have this acute and massive clinical picture. What to do, what to decide. So those are the things that then you sometimes think, why am I doing this type of work? Because it brings you in ambiguity. Maybe you do something wrong and you don't know where to keep on. It's not easy. So thank you so much.